All right, so moving on. ECG rhythm interpretation and analysis. We've talked about the ANP. We've gone over the electrical properties of the myocytes. We've talked about how to lay out the leads and how the leads measure that flow of electricity depending on what angle you're looking from. Again, focusing on lead 2 as the primary one that we'll be using for this lecture. Now it's time to take and apply a standardized structured method to analyzing these rhythms in order to figure out what the heck you're dealing with. So here we go. So there's a couple different methods you can use to approach an EKG strip to try and break it apart and figure out what all the pieces are. This is essentially what I was trained to do and the sequence that I use. Some of these things you just do simultaneously and you can do more than one at once. But as you're learning and you're trying to kind of get a feel for everything, I recommend just starting with this sequence and then building from there. So, rate, what are we looking for? Well, we're looking to see if it's normal, fast, or slow, right? And so normal being 60 to 100 beats per minute, right? Regularity, which you can do almost at the same time as you're doing your rate, but you're looking to see if it's regular or irregular. And this is something you can do from arm's length. You don't even really need to measure. You can just look at it. Does it look irregular or not? It's pretty straightforward. If it's irregular, look to see if there's a pattern involved. If there's any type of cadence or something going on along that line. And lastly, you're looking to see if there's any ectopic beats. And that really kind of ties in with the irregularity, because you ask the question, why is it irregular? Is it due to any ectopic beats? And so those two kind of feed into one another. When it comes to your P waves, we're looking to see, well, one, are they present? Are they upright? Because again, in lead 2, your P waves should be upright. Are they uniform? And then are they regular? And what I mean by that is your P to P, so the start of one P wave to the start of the next P wave, is that consistent throughout the entire strip, or does it change? Because that can be a sign of something that's going on. And is there one P wave for every QRS? Are there more P waves? Are you missing P waves? That's what you're trying to ascertain there. And that's essentially what you're looking for with the P waves. Now for your PRI, which you can only measure if you have P waves, but with the PRI you're looking to see if it's constant, and you're looking to make sure that it's between 0.12 to the 0.20. Anything longer or shorter means you've probably got some kind of an arrhythmia going on. And again, with your PR interval, you're looking for that consistency, but you're also looking to see, is there any kind of patterns involved there as well. Finally, your QRS complexes. You're looking to, one, see if they're present. Two, are they uniform, identical? You're looking for any kind of ectopic ones. And that ties in a bit with a few of the other steps, but still, it's important to just ask the question. Is there any pattern? And, of course, is it between 0.06 seconds long? If it's any longer than that, well, that means you've got a problem going on there. So that's essentially my approach. So let's just go ahead and practice. just to refresh your memory before we go in, we have our isoelectric line, our P wave, our QRS, and our T wave here. This is the PRI between this space here and here. And of course, this space from here to here is the QRS. And this little spot right here is called the J point. And this is your ST segment from here to here. And last but not least, from this starting point right here all the way out to the end of your T wave is your QT interval. So when it comes to finding the rate on any EKG strip, there's a few different methods. I'm going to show you 3 different ones, but we'll start with this first one, which is for irregular rhythms. And since we're doing rate, and what you're going to do is you're going to count the number of R waves on a 6-second strip and multiply them times 10. Well, how do you know if it's 6 seconds long? Well, you could go through and count every single one of these and try and figure it out that way. Or if you look right here at the top, you'll note that there's a darker hash mark, and again over here at the far side it has one as well. And those are marked every 3 seconds, which then makes the math a lot easier, right? If you got 2 solid marks, there you go. And I'll make the effort to circle those on all of the strips today. That way you'll have a chance to really see those. So we have an obviously irregular rhythm. There's no pattern to it that we can see just by staring at it right here. So because it's irregular, we can use this count method. So I will just count the number of R waves. And I've got 5. So 5 times 10 equals a rate of about 50 beats per minute. It's just that easy, which funny enough actually happens to match. Doesn't always, but matches in this case. All right, and so here's your other 2 methods. Now the first one was pretty broad. This method B is also fairly broad, and basically it just gets you in the ballpark. And yes, I realize that's several B's in a row. But the idea is this: if you memorize this sequence of 300, 150, 1, 75, 60, 50, 40, you can get a rough estimate of how fast a rhythm is going simply by bouncing along. And the idea is that you go with every large box or every 5 small squares. And so in this case, your R wave started right here. And so if we go 3, 150, 175, this patient has a heart rate of 75 on the nose. If it had fallen in between here, though, it would have been much more difficult. We would have wound up with a range of 100 to 175. Now, method C, which is much more accurate, again, only works for regular rhythms. If it's irregular, well, then you're going to get a different number between each R wave, and it just kind of defeats the whole purpose. So what we would do is then from the start of an R wave, which is right here, or tip of the R wave, I should say, to the tip of the next one, which is right here, we count the number of small boxes. In this case, it's pretty easy. Now, each one of these darker grid lines represents 5 small boxes, correct? So we can say that from here to here is 5, here to here is 5, 5, and another 5. So all told, that's 20 small boxes. So the number we get, we actually divide into 1500. And the 1500 will be the same every time. And 1500 divided by 20 equals 75. Not surprising, because these 2 rhythms are identical and they've got the exact same rate. So best practice would be to drill down and use that number whenever you can. And in fact, you can use this to do all sorts of things, to tell if the P waves are regular, the P to P. You can use the bounce method or small box, any number of things. So my plan is I'm going to use the exact same strip for the next handful of slides, and I'm just going to build upon each one of the pieces that I've mentioned before. We'll go over rate, and then I'll show you how to find regularity. Then I'll show you how to analyze P waves, how to do the PRI, and then finally the QRS. And all of it will just build upon itself as we go through this. So we'll just start out nice and simply. If we're going to do rate, we'll look for our little mark in the center, and same over here on the far side. So I know it's a 6-second strip, but I'm going to go ahead and mark these out anyway, just so you can see. And I actually plan on doing this for all of the strips throughout the presentation, just so that way we can, when I talk about beat number 6, you know exactly which one I'm talking about. So we have 8 total beats. So if we were going to do the most simplified method, we would take 8 times 10, and that would give us a rough estimate of 80. Well, let's try the bounce method, shall we? And so we'll look for one of these that starts on a solid line, and none of them really do. So we'll take this one because it's awful close, and we'll jump over 3, 150, 1, 75, and so it's between the 100 and the 75 mark. So 100 to 75 beats per minute, and we will note that it's a little closer to the 75. Overall, that tells us it's normal, correct? So at that point, I can say that these two confirm that we have a normal rate between 60 and 100. But because this actually is really regular, if you look across the screen, so when I ask the question of regularity, I can say, yes, it's regular. Let's count the total number of boxes, shall we? So we did this one across here, and we'll say it started right about here, and it ended just after this third small square, so right here. So let's count. I've got one large box, so I got 5, 10, 15, 16, 17, 18 and a half. And then this one was another half this direction, right? It's kind of in between. So that gives me a grand total of 19. So 1500 divided by 19 gives me 79. It's actually 78.9, but pretty much the same thing. And you can see how all 3 of these methods get me essentially in the exact same spot, correct? But again, it's important to try and use the most accurate one whenever possible. So that is essentially how you find rate. If you wanted to compare, if you were concerned, like maybe you were off a little bit or it looked a little irregular, you just repeat the process over again, and we could actually mark here and here, and then just count the total number of boxes across. And so it would be, we got 5, 10, 15, 16, 17, 18, 19 again. If I want to do the same thing for the P waves, it's from the start of the P waves here, and that's if I was going to find an atrial rate, because the QRS represents the ventricles, the P wave represents the atria, and you'd go across here. That one also comes out to 19, so perfect. All right, so continuing on, I kind of cleaned up the slide a little bit so there wasn't as much gunk in the way, but let's focus on our regularity now, or the rhythm. Is it regular? And we answered that question beforehand saying, yes, this is regular just by eyeballing it. Do we see any patterns at all? And in fact, there are none. It's just really straightforward. So we can say no patterns. And then do I have any ectopic beats? Anything that seems early or late or just out of place? And the answer is no ectopics. And it's really just that simple. Now, if I wanted to confirm that, of course, I would do what I did with rate, and I would mark out every single R to R, and I'd measure those, and etc., and do it on down the line to really prove it if I was ever curious. Using a set of calipers in real life is also really helpful, because then you can have them laid out in front of you and measure them out that way. Okay, now the P waves. You will find that the P waves and the PRI are the two most important items in really figuring out what most rhythms are, particularly when subdividing things. So it's worth taking extra time to really focus in on this part. So what are the P waves? Where are the P waves? Well, let's mark those out first. Let's just start right here. That's a P wave. There and there. And how do I know what the P wave is? Well, the P wave should be right in front of the QRS. And that QRS just stands out like a sore thumb, doesn't it? It's really tall. It's a pretty easy landmark to go off of. And so that P wave should be just in front of it. So I've marked all the P waves, and if you just eyeball them, you can really tell that they are all upright. They're all uniform. We asked the question, are they regular? Well, we actually measured that out on the rate slide. Yeah. Each P wave appears at the same timing every time. And then last but not least, is there one P wave for every QRS? And in fact, on this strip, there is one P per QRS. We're not missing any. We don't have any extras. And that's pretty much all we're focused on for now. And that is the P waves. Well, now that we've got our P waves marked out, it's time to start looking into the PRI. Now, you cannot measure a PRI without P waves. So how do we go about doing it? What's the easiest way to measure PRI? Well, we're going to start with a nice easy one. This is a pretty good one. So my P wave starts right where it leaves the isoelectric line, right? So you got your isoelectric, and as soon as it comes up, that's the start of the P wave. Then it comes down, and then as soon as your QRS goes up, that's the end, and that's what you're measuring between. So I always like to choose a P wave that either starts on one of the solider lines, like this one over here, the P wave started on one, or where the PRI ends on a solid line, kind of like this one right here actually ends just about on a solid line. So we'll measure these two. And my P wave starts about right here. Now this is something I like to do, which is mark my measurements, not on the actual strip itself, but above or below. So then that way I don't wind up covering up the rhythm that I'm trying to interpret or trying to read. So if we measure these out, I've got 1, 2, 3.5-ish. Probably round up and just call that 4. And then this one here, I've got 1, 2, 3, 4. So right at 4. So if we take that, that's 4 small boxes. So if we take 4 times 0.04, that gives us 0.16 seconds, which is also normal. And as you saw here, I abbreviate normal by doing N with a cursive L. Anyhow, those are normal. We've in fact measured 2 of them, and they've come out to be the same, so we can pretty much say that the PRI is consistent across there. Last little bits that we'll add into this is the PRI constant, and we will have to just go ahead and say, and that there's no pattern to it either, because there will be certain rhythms where that is important. Okay, final step. Let's walk through our QRSs and see what we got. Now, to refresh, we've got a rate of 79. It's regular. There's no pattern. There's no ectopic beats. Our P wave is upright, uniform, and regular. There's 1 P for every QRS. The PRI is 0.16, which is normal. There's no pattern to that, and it's constant. So as for the QRSs, if we take a look, they are indeed uniform. So again, this is the QRS complex, and so we'll say that they are uniform. They actually have a pattern of QRS. And what do they measure? So let's go ahead and grab a couple here. This one starts on a dotted line, and this one here ends just on the other side of one as well. And so that is 2 small boxes. We'll measure another one just to be safe. Let's see who's a good one. This would be a good one right here. Here, and it ends about right here. 1, 2. So that one's about 2 as well. When it comes to half box, it's a little bit leaning one way or the other. It's a little bit difficult unless you zoom in and you're really looking in real life. But for these, we can say that they're quite easily 2 small boxes times 0.04, 0.08, which is also normal. So we have a normal QRS in that regard. There are no ectopics QRSs. So I have a normal QRS, I have a normal PRI, and I have a normal rate. So that all together says that this patient has normal sinus rhythm. Last but not least, I want to throw in on here, let's measure the QT just to practice that a little bit. And so the QT will be from the start of a QRS, which I've actually got one marked here, all the way to the end of a T wave, which I can say is right about here. So if we measure across those, that's 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 boxes. So if we take 9 times 0.04, 9 times 4 is 0.36, which is normal. So speaking of QT intervals, you're probably a little bit curious, just because I've mentioned it, but what does a long one really look like? Well, this is actually a pretty darn good example of what a prolonged QT interval can look like. Before I dig into the trigger part, let's just walk through it. Basically what happens is with a prolonged QT interval is that it's taking longer for the ventricles to recharge, to drag their feet, that kind of thing. And what happens is that T wave winds up happening much later than it should. So let's measure one of these real quick and I'll give you a good idea. We'll take this one right here because this Q wave, the QRS starts right here on a bit of a solid line and the T wave ends somewhere over here. That's right. In fact, this is the P wave, this is the QRS, and way out here is the T wave, and then the next P, and then the QRS. So that T wave is way out here, and it actually mixes with the next P wave, so it's really impossible to tell where one started, where one ended. So we just kind of strike the average and say that it probably stops somewhere around here. So this space through here, that's about 5, 10, 11, 12. So that is 12 spaces. It's 12 small boxes, sorry. So if we take 12 times 0.04, we get, and yes, I actually have my calculator out just to make sure that I get these numbers exactly right for you guys. Gives us a 48.48. Now, to refresh your memory, what's normal? That's going to be 0.36 to 0.44. So that is longer than it's supposed to be, for sure. Why do we take the time? Why do we talk about this? Well, prolonged QT intervals run the risk of popping into a special type of VTAC, ventricular tachycardia, which is a lethal arrhythmia. And so we want to do everything we can to prevent this. And what's really interesting is some people congenitally have this problem, but in most cases it's actually an acquired an acquired problem. And believe it or not, it's mostly our fault. Patients who are receiving antiarrhythmics are at increased risk. If they're on antibiotics, increased risk, antipsychotics, antidepressants, all the antis are involved. And what makes this particularly dangerous is when you have multiple medications that actually stack on top of each other and can make things much, much worse. So you can take someone who normally has a healthy QT interval and stretch it out by giving them these different medications, which then leads them to present with these types of problems. Well, how do these patients even present? Well, a lot of your primary symptoms are syncope, palpitations, or sudden death. So lots and lots of reasons to keep track of this. So when the alarm goes off that they have a prolonged QT interval, stop, take a look, figure out what medications they're on. Did we just start a new medication that may have led to that? Other important things to just keep track of is low electrolytes. So magnesium, calcium, potassium. If they've had a head injury, hypothermia, if they're really, really cold for whatever reason, accidental or intentional, and then really early on in an MI, cardiac ischemia, can also have this kind of effect appear. So just keep track of those things. That's why it's important. So as you might have noticed, the alarm that tends to go off most frequently is actually going to be your QTC alarm, which is very, very similar. What makes this important and actually a better measure of your QT interval is this. So when your heart rate is going fast, because everything is sped up, that actually makes your QT shorter. And then when you have a slow heart rate, it equals a wider QT. So in the same individual, when their heart rate changes, how do you adjust for that so that you can compare someone with a tachycardic heart rate to someone with a, let's say bradycardic heart rate? Well, what you do is you correct for it. And so that's what this graph represents, is how to correct for the QT based on how fast their heart rate's going. So let's just take a quick example. So let's say we have someone who's going at 60 beats per minute and someone that's going at 110, and see what we get. So at 60 beats a minute, if we come up here, and we'll just, pink is of course your average, and that's going to land here, which is about right here. So that's a, QTC of about 380. Now that same person, if their heart rate is going 110, is about right here. So if we follow along, has a QTC of 280. And that's how you can compare those two things together. So if I measure one that's 380, that's maybe a little bit long. Well, no, in reality it's not. That's been corrected for the speed that they have. Now if you want to see what the upper end of normal would look like at 60 beats per minute, well, then that's what this guy's going to be up here, where your upper end is probably in the .440s or so, and vice versa at 610, upper end of normal. If we do the yellow line here, that traces across to about right here, which we'll say is probably about 320. So that's a point of QTC, is so that you can compare apples to apples, oranges to oranges. This is probably what's really important. The upper end of normal is 500. And you can essentially say that anything greater than 500 millisec is not normal. And you probably noticed that already. When it comes to QTC, we actually represent that not as a 0.28 seconds, but instead we call it 280 milliseconds. Essentially the same thing, very similar measurement, it's just the way things are communicated. Now, you're likely to actually have some elevation in the patients that come through a hospital, simply because they may have a history of cardiac disease or medications that they're taking on purpose to slow down their heart rate, and one of those side effects is QTc being widened. What's most important, though, is it worsens with severity of cardiac dysfunction. So if their heart is doing poorly, the QTc will get worse. So keep track of that, kids. Okay, so you've heard me mention it a few times already, but I'm finally actually going to sit and show you what I'm talking about. Premature beats are ectopic beats. Specifically, they're early. Now, what are a couple good examples? Now, without knowing the names of these, it's just the idea that I want you to see here. So I'll label these 1, 2, 5. And the idea is you have this normal beat. It's got the P, Q, R, S, T. And then there's another beat that's right here. Well, if you actually step back and look, you'll see that beat number 2 and number 4 are both earlier than they should be. You know, if you were going to try and just eyeball it and pick, you would expect that QRS to be somewhere about here, right? More of the halfway point from a regularity aspect, but it's not. They're actually early. It's happening sooner than they should. So what you'll do is you'll still count the number of beats on the strip, you'll multiply times 10, all that jazz, and you'll analyze these beats first to figure out what the underlying rhythm is, and then you'll go and try and figure out what these early beats are. And you'll notice this one here doesn't even have a P wave, and its partner down the way doesn't either. And so the quickest, simplest thing that you can do is, one, eyeball it, look for it, but when it asks that regularity question, your answer is going to be no, and that there is actually a pattern, and that you have ectopics. Another example down below here, and we'll number these again. So, looking through this strip, you can tell that it is irregular. And there's a number of beats that, well, what you really notice first is these gaps that are occurring right through here, here, and here. And then if you take another moment and you look, you'll see that this is extremely narrow by comparison to those other ones. So that what your best estimate would be is that 2, 5, and 8 are your early beats, and that the rest of them are actually spaced out pretty well. Because if you just moved 2, 5, and 8 over a little bit to the right, it would balance things out. So we'll say that there is a pattern, and there are ectopics. What's the pattern? Every third beat is early for some reason. Now, to help finish proving that they're ectopic, we just have to go through and analyze them the same way we would anything. We start out by analyzing what the normal rhythm looks like, and then once we're done with that, we come back to the ectopic ones and look at them to see if they match and any other details that we can pull out of them to figure out what's going on there. What's really interesting is, you know, if you assume beat number 2, 5, and 8 are essentially alike, they all have, well, 2 and 8 have P waves in front of them, whereas beat number 5 does not. However, I'm going to erase this real quick. You'll notice that beat number 5, that P wave is right in there at the same spot where the T wave is, and so that they're probably mixed together. Either way, we've got a pattern of irregular early beats in this case. Identify your understanding of the rationale guiding the use of a systemic approach to ECG interpretation. One standpoint is that ECGs were designed by type A people, so that's why we use an organized sequence for reading strips. Seems a little bit stereotypical, but it's probably not wrong. I feel like it was probably type A people that did a lot of this work, but that's not the point for why we use a systematic approach. If we look at B, ECGs are often complicated, which is the truth. Therefore, the use of a consistent and thorough approach to interpretation helps learning the rhythms and mitigates the risk of overlooking or potentially missing important features, which is the big thing, and that's the truth. That's why we use a systematic approach, is to remain consistent, remain thorough, and not overlook things, because that, could lead to problems down the road. Third one, just to check and see, I can look at it and tell you what it is just by recognizing it. The systematic approach is a waste of time for me, but I guess it helps some people. There are some individuals that are at that point where they just recognize it better than they can measure it, and that works well for simple rhythms. But when they start having multiple things wrong with them, you really do still need to sit down and apply those skills again. So some people do work in the realm of C, but that's not why we learn the systematic approach. B is your true answer for this question. Identify the best method for estimating the heart rate for this rhythm. This is a 6-second strip. So the first thing, you're just going to look back and ask the question, regular or irregular? And because this strip is quite obviously irregular, that's going to change your entire approach to this. If it was regular, well, then you're going to be doing measurements of the small boxes or large boxes and the math that goes with them. And so remembering that small boxes get divided into 1500, large boxes get divided into 300. But that's really not the case. Because this is irregular, we're really just going to count the total number of beats and multiply times 10 to get the answer. So we have a heart rate of about 140 beats per minute. The monitoring system is alarming QTC 650 milliseconds. You look back and find out that it was 425 yesterday. Which intervention should be performed? Well, is this emergent or a non-emergent item? As of right now, you have to ask the question, what's normal? And so looking back, for men and women, it's slightly different, but ultimately we don't get excited until it's greater than 500 millisec. So at this point, the patient has a QTC that's greater than 500, and so we need to react accordingly and ask again, is this an emergently high item, or is it just something that we need to keep a close eye on? And the truth of the matter is, as long as they're still in a normal sinus rhythm or something like that, it's not emergent. So for this, it's not a false alarm. And I'm not going to say that these are emergent. And so telling the CNA really won't change anything, because it doesn't have to do with lead placement or anything of that nature. It really just leaves us with non-emergent, but notifying the primary nurse of the rhythm change so that they can go through and figure out what the cause of that is, or work with the provider. Prolonged QT interval and or QTC is associated with risk for what lethal rhythm? And so just look through the list. Which of these are lethal? Well, AFib is not a lethal rhythm. Third degree heart block can be lethal, but that doesn't really have to do with the prolonged QTC. Pulseless electrical activity, also not in that realm, which really just leaves us with the polymorphic ventricular tachycardia, also known as torsades. And that's the truth here. The big lethal rhythm risk for prolonged QT interval is to wind up with a polymorphic V-tach. The monitor tech has notified you that the patient's QTC has increased from 425 milliseconds yesterday to 650 milliseconds today. Which combination of new medications may be responsible? And so this is a question of what medications are well known for causing a increase in the QTC for patients. And kind of the hint I gave you the other day was with the presentation is using the antis. So stuff like, is it analgesics? No, not really. Is it antiarrhythmics? Yes, it is. Makes sense because some of those drugs specifically slow down the heart. Antibiotics, particularly levofloxacin, also known as Levaquin. That's a really good one. Antipsychotics, particularly haloperidol. That's a big one. Anti-inflammatories, no, steroids really don't mess with your heart rate all that much, so it's not anti-inflammatories of that nature, but antidepressants can, and so in combination of the antidepressants, antipsychotics, antibiotics, antiarrhythmics, those are the big ones that you really have to watch out for, and those are the four that I would say you need to look at. Please identify the type of ectopic beat displayed. Well, which one are we looking at? Well, we've got one here, and we've got one here. And those appear to be on the early side, happening sooner than they should. So at that point, we're not dealing with an escape beat. We're not really looking at U waves. We're looking at premature beats. And at that point, we have to ask, is it aberrant conduction? And I would say no, because your QRS looks essentially identical to the one before it. So at that point, I would say this is just a premature beat.